Good evening, everybody. So, see, today is the 12th day of our 1 month course. So, in today's lecture, we'll discuss some cases. We have previously discussed about leukemias and lymphomas. Okay, in previous classes, we have discussed about leukemias. In leukemias, we have two main types. Okay, myeloid leukemias and lymphoid leukemias. In myeloid, we have acute myeloid leukemia and chronic myeloid leukemia. And in lymphoid leukemias, we have acute lymphoid leukemia and chronic lymphocytic leukemia or chronic lymphoid leukemia. Okay. So these four types of leukemias we have already discussed. And along with this, we have discussed about lymphoma. Lymphoma. In lymphoma, we have two types. In lymphoma, we have two types. One is Hodgkin's lymphoma, and one is non-Hodgkin's. You can pronounce anything. Okay. Hodgkin's lymphoma and non-Hodgkin's lymphoma. These all concepts we have discussed in previous classes. So we will try to discuss cases related to these leukemias and lymphomas, number one, and then we'll discuss the pharmacology of purine analogs. Okay, these are anti-metabolite agents. Anti-metabolite agents. In that, purine analogs we'll discuss because in cases few drugs from these purine analogs are there. That's why I have taken this in today's topic. And along with that, very important, recently approved drugs, tyrosine kinase inhibitors. So about these drugs also we'll try to discuss, and I'll try to introduce about the course in mycme.com. So that also we'll discuss today. So in today's lecture we'll discuss about these three concepts. So let's begin our class with this case. I think you have already gone through this case. So let me read this case for you. See, a 57 years old man, male patient, who is having history of 6 years chronic lymphoid leukemia. Patient is having chronic lymphoid leukemia or chronic lymphocytic leukemia, and patient is having clinical presentations of elevated white blood cell count. Okay, white cell count were increasing in the body, and along with that, patient is having worsening lymphadenopathy. Patient has lymphadenopathy, and along with that, patient has hepatosplenomegaly. Patient's hepatic tissue was enlarging, and spleen is also enlarging. That is called hepatosplenomegaly, where hepatic tissue and spleen tissue both will increase their size because of the infiltration of white cells or lymphoid cells into these tissues. So these three are very important clinical presentations patient is having. So in this patient who is having chronic lymphoid leukemia for 6 years, and this patient was prescribed with three drugs. In that, the first drug is fludarabine, very very important drug, and one cyclophosphamide. The about cyclophosphamide we have already discussed. Okay, this is alkylating agent, and along with this two, rituximab is added. Rituximab, which is given for 1 day, and this strategy, this regimen is called FCR regimen. So in this patient, 6 years history patient, in this patient, three drugs were given: fludarabine, cyclophosphamide, and rituximab. Okay, this treatment is given. Now, the question for this case is, if this patient is using these three drugs, being a clinical pharmacist, when patient comes to us, to the clinical pharmacist, what additional precautions will you give to the patient as well as to the physician? When physician is prescribing these three drugs, what important points or what important uh, counseling points you will advise to the patient as well as to the physician is the question. Okay, I think you all understood this case. Patient is male, 57 years. Patient is having chronic lymphoid leukemia for 6 years, and patient is having increased white blood cell lymphadenopathy, hepatosplenomegaly, and this patient is treated with or prescribed with fludarabine, cyclophosphamide, and rituximab. Okay, this is the case. See, to solve this case, in previous classes already we have discussed about cyclophosphamide. Cyclophosphamide is the alkylating agent, its adverse effects and its mechanism, everything we have discussed. Some important points about cyclophosphamide, let me revise. See, this cyclophosphamide has many general toxicities. Okay, it is having general toxicity on each and every tissue, but the specific adverse effect which is associated with cyclophosphamide is, can anyone tell me the specific adverse effect associated with cyclophosphamide and iphosphamide? Anybody? Hemorrhagic? Hemorrhagic? Yes, hemorrhagic cystitis is the very, very important adverse effect, specific adverse effect associated with cyclophosphamide that we have already discussed in previous class. And about rituximab, I think I have not discussed, but see, about rituximab, it is very easy. This rituximab is the monoclonal antibody. It is monoclonal antibody, and this rituximab specifically it kills the B cells. This one you have to remember. The B cells which are having CD20. or the B cells which are presented with CD20, because rituximab binds on CD20 B cells and it kills the CD20 B cells, and through that it will destroy the neoplastic B cells. Okay, so that is the important point about rituximab. And rituximab, being a monoclonal antibody, when these antibodies are infused to the body, main adverse effect what they cause is they will cause infusion related adverse effect, that is rashes or allergic reactions, mainly allergic reactions they will cause. Okay, and other important points about rituximab we'll discuss later. So as of now, cyclophosphamide is causing general toxicities starting from every tissue. In the mouth, it causes toxicity. On the rapidly dividing cells, epithelial cells, it causes nausea, vomiting, diarrhea. Okay, it causes stomatitis. It decreases. It causes infertility. Okay, and the specific adverse effect is hemorrhagic cystitis. That all that anyways we have discussed. Okay, now we will try to discuss about fludarabine. This is very important drug. About discussing about this fludarabine, we'll come back to the case. Okay, I think you all understood this case. Now, before understanding about the fludarabine and all, see, patient is already suffering with chronic lymphoid leukemia. See, what is the difference between acute lymphoid leukemia and chronic lymphoid leukemia? Who will tell? The difference between acute lymphoid leukemia and chronic lymphoid leukemia. Simple. First difference is in acute lymphoid leukemia, the origin of the disease is very rapid. The onset of disease is acute. Immediately the disease will occur. Okay. And in acute lymphoid leukemia, it is very common in children. This point already I told. It is common in children, and chronic lymphoid leukemia is common in elder population. First difference. Everybody should try to revise, understand. Okay, acute lymphoid leukemia is common in children, and it occurs rapidly. And in chronic lymphoid leukemia, it occurs very slowly, and it is common in adults. And see, in acute lymphoid leukemia, we have, I already discussed, it is of three types: L1, L2, L3, based on the morphology of different lymphocytes. Okay, here particularly lymphoblast cells are important characters in acute lymphoid leukemia. Okay, in acute lymphoid leukemia, patient is characterized by lymphoblast cells. These are immature cells. Lymphoblast cells are elevated in the blood smear. Okay, and here in chronic lymphoid leukemia, here along with lymphoblast, particularly B cells are elevated. B cells are elevated. Chronic lymphocytic leukemia, I already told. Chronic lymphocytic leukemia is mainly characterized by presence of B cells, I told. So this is another difference. And in treatment, you see, in acute lymphoid leukemia, I told three drugs mainly. Okay, vincristine I told, prednisolone I told, and one enzyme I told. What enzyme I told? L-asparaginase. L-asparaginase is the enzyme which is very effective for acute lymphoid leukemia. And along with that, few other drugs like daunorubicin, doxorubicin also we can give. So these are four drugs which is very effective for acute lymphoid leukemia. And in chronic lymphoid leukemia, always remember, there is no specific drug. Okay, because it is not having proper curing ability. It is not cured. Always remember, acute lymphoid leukemia is having good prognosis with chemotherapy, whereas chronic lymphoid leukemia has very less prognosis with the chemotherapy and radiation therapy. That's why we don't have a specific drug regimen. However, this chronic lymphoid leukemia is mainly characterized by the presence of B cells. That's why here we have certain regimens which is mainly included with rituximab. Why rituximab is included here in treatment regimens for chronic lymphoid leukemia? Because rituximab is mainly focusing on killing B cells. Because here chronic lymphoid leukemia is mainly characterized by presence of B cells. That's why. And along with rituximab, we can go with other alkylating agents, cytotoxic drugs like cyclophosphamide, and fludarabine is another very important drug. So in combination with cyclophosphamide and fludarabine, rituximab is common regimen which is given for chronic lymphoid leukemia. This is the difference you should understand. Okay, and sometimes in chronic lymphoid leukemia, because it is a chronic condition, here sometimes the B cells and some lymphoid cells will infiltrate into certain tissues, and with that it will cause lymphoma. Okay, leukemia can cause lymphoma, and lymphomas can again cause leukemia. That you have to remember. Okay, and here one more point: in chronic lymphoid leukemias, it can go and infiltrate into certain tissues, and it will cause splenomegaly, or hepatomegaly. In hepatic tissues, it will be infiltrated and it causes hepatomegaly. And sometimes these B cells or lymphoblast cells in chronic lymphoid leukemia, certain lymph tissue also, okay, lymph nodes also involves, and it causes lymphadenopathy. lymphadenopathy. So here in our case, already patient is having splenomegaly, hepatomegaly, and lymphadenopathy. These are the infiltrated conditions, because in chronic lymphoid leukemia, these conditions are very common, because it is not arising in 1 day, 2 days, or in 1 month. It is arising for years. That's why the infiltration of the tissues is very, very common. And in our case, already patient is having this chronic lymphoid leukemia for 6 years. That's why patient is having lymphadenopathy and hepatosplenomegaly. Okay, so I think you understood the difference between acute lymphoid leukemia and chronic lymphoid leukemia. This is just a revision. Okay, now to understand about this and this yeah, about chronic lymphoid leukemia, already I told about the pathogenic events. Mainly it is caused due to the genetic cause, the deletion of 13th chromosome and trisomy patients, deletion of 11th chromosome, deletion of 17th chromosome. All these things we have already discussed in previous classes, and this about chronic lymphoid leukemia we have discussed. And I told one more point. Chronic lymphoid leukemia, just now I told, it is mainly characterized by the presence of B cells, right? And these B cells are very fragile. In the smear, if we see, the B cells are ruptured. These ruptured B cells are called smudged cells. These all points we have discussed. Based on this smudged cells, we can diagnose that patient is having chronic lymphoid leukemia. All these things we have already discussed. Just I am revising. See, one point you have to remember: if patient has lymphadenopathy in chronic lymphoid leukemia, we will go with analgesic agents. Analgesic agents. In analgesic agents, we have opioid drugs, NSAIDs, and all supportive treatment. Or sometimes we can remove the lymph nodes also from the tissue. Lymphectomy we can do. Lymph nodal removal surgeries we can do if specific localized area if it is there. And if patient is having involved with splenomegaly, if spleen tissue is involved with the tumor, so we can remove the spleen from the body. That is called splenectomy. Okay, splenectomy can be done. And if patient is having hepatomegaly, we can't remove hepatic tissue because it is very important for us. So in that cases, radiation therapy we can give. Radiation therapy, and along with the chemotherapy, we can give cyclophosphamide, fludarabine, and rituximab. These drugs we can give. Okay. And if patient has lymphoma, in lymphoma cases, we have different regimens like CHOP regimen. Okay, all these regimens we have already discussed in lymphomas, in non-Hodgkin's lymphoma and in Hodgkin's lymphoma. Okay, so this is just a revision of acute lymphoid leukemia and chronic lymphoid leukemia. See, now let me explain you about the drug information of fludarabine, because patient is having fludarabine. If we understand about fludarabine, then we'll try to solve the case. Okay, so fludarabine is the drug which is coming under the class of antimetabolites. Actually, see, in antimetabolites, we have folate antagonist. In that, methotrexate is very important drug. And in antimetabolites, we have purine antagonist or purine analogs. We call them purine analogs. They are very, very similar to purines. In that, we have 6-mercaptopurine. We have thioguanine, 6-thioguanine, azathioprine, and fludarabine. All these are purine antagonists. Okay, along with this, we also have other drugs. Also, let me tell you. And these are purine antagonists, and we have pyrimidine antagonist. In pyrimidine antagonist, 5-fluorouracil, cytarabine. About cytarabine in previous class already it came. I'll explain this drug also. So these are different drugs which comes under antimetabolites. In this, fludarabine is the drug which is coming under the class of purine antagonist. Okay, or purine analogs. So we'll try to discuss about this purine antagonist, and then we'll solve the case. See, yeah, in the examples of purine analogs or purine antagonist, we have mercaptopurine, thioguanine, azathioprine, fludarabine, which is very important drug, which is the example in our case, cladribine, pentostatin. It is not a statin, but it is a pentostatin, and nelarabine. All these are the examples of purine analogs. Purine analogs. Okay, why they are called purine analogs? You know why these drugs are called purine analogs or purine antagonists? See, always you should remember. Just imagine this is a DNA. Okay, this DNA is formed from the bases of purines and pyrimidines. Okay, purines and pyrimidines. Purines and pyrimidines are the bases, or these bases are building blocks. These are building blocks of DNA and RNA. DNA, RNA, this DNA, RNA are the nucleic acids. These nucleic acids are made up of these bases, which are purines and pyrimidines. In purines, what we have? In purines, we have adenine and guanine. Adenine and guanine are the purines. And pyrimidines, what we have? Cytosine, we have thiamine and uracil. These are CTU. These are pyrimidines. Yes, these purines and pyrimidines are the building blocks of DNA and RNA. DNA and RNA. DNA, RNA are the macromolecules which are synthesized from the bases of purines and pyrimids. Okay, and now we are discussing about the purine analogs, or these drugs are very similar to purines. These drugs, purine analogs, are very similar to purines. We have adenosine, okay, or adenine, guanosine, adenosine, guanine. Adenine and guanine are purines. Okay, these drugs are purine analogs, are similar to purines. Now you see, just try to remember this. Yeah, the purines, adenine and guanine are the bases which are important in making DNA and RNA. And in pyrimidines, we have cytosine, thymine, uracil. All these are basic things you already know. Just for understanding purpose, I'm telling. These purines, adenine and guanine, these compounds are very similar to these drugs, or those drugs are very similar to purines. Okay, so now let's understand the pharmacology of these purine analogs. I think everybody are following me. Purine analogs are the drugs which are very similar to purines. Their chemical structure is similar to purines. Purines are adenine and guanine. Okay, so now the mercaptopurine and thioguanine. These are first compounds which are these compounds are very similar to purines. Now let me tell you the mechanism of these two drugs first. Mechanism of action. These two drugs are having very similar mechanism of action. I think everybody are following me. Any confusion to anybody? Are you all following me about purine analogs? The drugs we are discussing is purine analogs. Are you all following me? Yes. Yes. Very good. Now you see this mercaptopurine and thioguanine are the first example. These are initial first drugs. These are first drugs. When purines were studied, these drugs were initially studied. Okay, these drugs, what they do when these drugs are given to the patient. Hmm. When these drugs are given to the patient in the body, when they are administered either through oral route or they are available in IV form also. When they are given through oral route, once they enter into the body, what happens? In the body, these compounds are converted. They are activated. They are having many conversions. Okay, they are converted into thioguanine, thioguanine nucleotide. This is one form of the drug. This mercaptopurine and thioguanine, when they are entered into the body, they are converted into thioguanine nucleotide. And this thioguanine nucleotide is very similar to purines. Okay, so this thioguanine nucleotide, what it does, it will help in the formation of DNA. In the DNA formation, this thioguanine nucleotide will enter into the DNA here, somewhere here. And what it does, during replication of the DNA, this thioguanine nucleotide is false base. It is a false base, no? This is a false base because it is coming from the drug. It is coming from the drug. It is not an actual purine. It is not an actual purine. It is similar to purine. So when thioguanine nucleotide enters into the DNA during its replication, due to the false effect of this base pair, the replication of DNA will be stopped. There is no replication of DNA. Okay, that's why these purines, this mercaptopurine and thioguanine, what they do, they will decrease the DNA replication, DNA and RNA replication or their development. With that, it will stop replication and it will kill the bacteria. It will kill the neoplastic cell, or it will stop the proliferation of neoplastic cells from there. To proliferate, DNA should undergo replication, and this DNA undergoes two mitosis, and again it forms two new cells that we have already discussed. So here, these drugs, what they are doing, they are stopping the replication of DNA by entering into the DNA, and they are entering into the DNA as false base pairs. Okay, and with that, they will stop the formation of daughter DNA molecules. Okay, that is DNA replication. I think you understood the mechanism of mercaptopurine and thioguanine. And all other drugs are having similar action, but slightly they are different. I think you all understood the mechanism of action of mercaptopurine and thioguanine. Thioguanine, 6-thioguanine. Clear? Now let me tell you the important features, very important points about these drugs. Okay, initially we'll start with the pharmacokinetics, ADME. I will tell only important points. Always you have to remember. Okay, always remember these important points. We are talking about 6-mercaptopurine and 6. What is the name? Thioguanine. Okay, 6-thioguanine. I'm talking about the ADME. See, these drugs are available through oral form as well as through IV form. First point. Okay, one important point: when these drugs are given through oral routes, always remember when they are given through food or through antibiotics, or along with other compounds, especially food and antibiotics. when these drugs 6-mercaptopurine and 6-thiaguanine are given through oral route particularly, if they are advised through food and antibiotics, their absorption decreases, bioavailability decreases. So always advise them in empty stomach. Important point. It is the important point of clinical pharmacist. Clear? Next important point. If these drugs are 6-mercaptopurine and 6-thiaguanine are given along with methotrexate. About methotrexate, I will explain you about this is very, very important drug. If these drugs are given along with methotrexate, always remember bioavailability increases. Bioavailability increases with methotrexate if they are given along with methotrexate. Another important point. Clear? And see, when it is given, they are absorbed from the GI tract. This interaction you already understood. They are distributed in the body. And in metabolism, when it comes about metabolism, always remember we have two enzymes for the metabolism of 6-mercaptopurine and 6-thiaguanine. Number one, xanthine oxidase. Xanthine oxidase is one enzyme which tries to metabolize this 6-mercaptopurine and these drugs. And second method of metabolism is there is one important enzyme called thiopurine methyl transferase. Thiopurine methyl transferase, which is also called as TPMT. Very, very important enzyme this is. Thiopurine methyl transferase. Always remember these two examples, these two enzymes. Xanthine oxidase, you already know. We have already studied about xanthine oxidase inhibitors, which is important in gout condition. Okay. Patients who are having hyperuricemia, wherever uric acid levels are increased in the body. In that cases, xanthine oxidase inhibitors are given. This enzyme is decreasing the production of uric acid. This is another method. Anyways, this about this enzyme we already know. That concept you just forget. Now, xanthine oxidase is also present in the blood as well as in the liver. So in the blood, this xanthine oxidase, what it does, it will try to metabolize the 6-mercaptopurine and 6-thiaguanine drug. And the second enzyme which metabolizes is thiopurine methyl transferase, TPMT. These two enzymes will try to metabolize these two drugs, right? This is one important point. If if xanthine oxidase inhibitor is given to the patient along with these two drugs, what will happen? If xanthine oxidase inhibitor is given to the patient who is taking 6-mercaptopurine and 6-thiaguanine, what will happen? Anybody from the class? Yes, metabolism of 6-mercaptopurine will be decreases and it causes toxicity. Okay, it causes toxicity. So never advise xanthine oxidase inhibitor along with 6-mercaptopurine and 6-thiaguanine. One important point you understood. Okay. Number two, here, if xanthine oxidase inhibitor, if patient is having hyperuricemia, in that cases, in few cases, compulsory we have to give allopurinol, febuxostat. We have certain examples which are xanthine oxidase inhibitors. In that cases, always we have to monitor 6-mercaptopurine and 6-thiaguanine. And or if in that cases we have to reduce the dose, 25% of the dose should be restricted and we'll go. Like that also we can go, but actual dose we should not keep. This important point you have to remember. Number two, see, thiopurine methyl transferase, this enzyme, it is the very, very important enzyme in the liver. In the liver, it is very important enzyme. See, most of the few populations, what happens due to the genetic variations, due to the mutations or particularly genetic variations, this enzyme is having more probability of causing polymorphism. This enzyme is very, very polymorphic. When this thiopurine methyl transferase TPMT enzyme, if it is having polymorphism, what will happen? The polymorphic form of enzyme will not have activity. So in that case also, 6-mercaptopurine and 6-thiaguanine and drug will not be metabolized properly and its concentration will increase. About this TPMT, you will read in fifth year. In actually in therapeutic drug monitoring, we have one concept called pharmacogenetics. In pharmacogenetics, this enzyme will come. Okay, so remember one important point: this TPMT enzyme is having high polymorphic ability. So if patient is having polymorphism of this enzyme, that polymorphic enzyme is not having activity. So in that cases, patient may have risk of developing toxicity. So in that cases, if patient is already polymorphic, so we have to restrict the dose. We have to decrease the dose and we should give. This is important point you have to remember about uh, this 6-mercaptopurine. Understood this point, everybody? Clear? Now, another important points let me add here. Let us see the adverse effects of this miricaptopurine and these drugs. See, these drugs will cause myelosuppression. First point, myelosuppression. With that, when bone myelosuppression is nothing but bone marrow suppression. If patient is having bone marrow suppression, what will happen? Patient will have thrombocytopenia. Patient will have granulocytopenia. Granulocyte will decrease. Patient will have anemia. Wherever the drug is having myelosuppressive action, those drugs will cause thrombocytopenia, granulocytopenia, anemia. Okay, and along with this, this mircaptopurine, this drugs is having more anorexia. Anorexia. Anorexia is loss of appetite. Anorexia, it causes nausea, vomiting, and very, very important adverse effect, it causes hyperuricemia. Hyperuricemia. See, just now I told one point, 6-mercaptopurine should not be given along with allopurinol or febuxostat, which are xanthine oxidase inhibitors, right? Already this 6-mercaptopurine is causing hyperuricemia. So in hyperuricemia, these drugs are drug of choice. So in these cases, what we have to do? Can anyone give me the answer? Say 6-mercaptopurine is causing hyperuricemia, and in these cases, xanthine oxidase inhibitor should not be given. So what will you do? If 6-mercaptopurine is drug of choice, and along with that, if patient is having hyperuricemia, xanthine oxidase inhibitors can be given, but 6-mercaptopurine drug doses should be decreased. Those should be decreased. And one more alternative we have to decrease hyperuricemia. Can anyone tell me what is the alternative? One more alternative we have for hyperuricemia. Yes, someone is answering. We have uricosuric agent, uricosurics. Can anyone give me the example of uricosuric agent? Yes, febuxostat, not febuxostat. Probenicid, very good. Probenicid. Here we can go with probenicid. Very good, excellent. Okay, so this is the alternative we can go. So these are important points about mircaptopurine and 6-thioguanine. Okay, now the next drug we'll discuss is fludarabine. Yeah, here actually these mircaptopurine and thioguanine and azathioprine, these three are very, very similar. See this azathioprine, what it does, azathioprine in the body, again it will be converted into 6-mercaptopurine. So again it is very similar like 6-mercaptopurine. So it is not necessary for us to study about azathioprine. Anyway, it's pharmacokinetics and all, it has few changes. I'll try to tell that. But now we'll focus on fludarabine. Okay, so fludarabine is very, very important drug. It is available in particularly in IV form. IV form. It is also available in oral, but mainly it is given in IV form only. Mainly in the hospital, it is given in IV form. Now you see. Now let me tell you about the mode of action of fludarabine. Initially, mechanism of action. Mechanism of action. See, fludarabine is important for our case. I will explain everything about this fludarabine because fludarabine is drug of choice in chronic lymphoid leukemia. It is drug of choice in lymphomas. Lymphomas, in few lymphomas, non-Hodgkin's, particularly in Hodgkin's lymphoma. In Hodgkin's lymphoma, fludarabine is very, very important drug. So listen carefully. See, first point about the mechanism of action of fludarabine. See, when fludarabine is given in the body, what fludarabine does, when it enters into the body, this fludarabine is phosphorylated. This fludarabine is phosphorylated into 2-fluoro ARA ATP. This fludarabine, when it enters into the body, it is phosphorylated. It is phosphorylated into 2-fluoro ARA ATP. And this phosphorylated compound, what it does, it has many actions. It will inhibit DNA polymerase. It will inhibit DNA polymerase, and we have so many enzymes in the replication of DNA. In that, other enzymes also, it will try to other enzymes will be inhibited by this 2-fluoro ARA ATP molecule. This is very important. And with that, what it does, it will stop DNA replication. DNA replication. It will stop DNA replication. Same like other, see, all these antimetabolites, these purine analogs will have they will stop DNA replication. So here, fludarabine, what it does, when it enters into the body, it is phosphorylated. See, it has many other mechanisms, but that all is not necessary for us. It is phosphorylated into 2-fluoro ARA ATP molecule that will go and inhibit certain enzymes in the body, which are important in DNA replication. And due to inhibition of those enzymes, it will stop DNA replication. Simple. Its mechanism is very easy. Clear? Now, I will tell you very, very important points about fludarabine. Listen carefully. First thing, it is useful in chronic lymphoid leukemia, and it is important in Hodgkin's lymphoma as well as non-Hodgkin's lymphoma. Okay, in these two conditions, it is used. Particularly in non-Hodgkin's lymphoma, it is very, very commonly used. Why it is commonly used in Hodgkin's lymphoma? I'll tell you. See, when this drug is given, when this drug is administered, very important point, its bioavailability is very low when it is given through oral route. But if it is given through IV route, its bioavailability is very high. First point, its bioavailability is low with oral route. Why? Because it is having high first pass metabolism. I think everybody know I think everybody knows about first pass metabolism. When it is given through oral route, what happens when the drug is given through stomach? When drug enters into the small intestine, immediately from small intestine it goes to liver. Okay, in the liver we have certain enzymes. So immediately from the GI tract, when it enters into the liver will try to metabolize the drug. The metabolism of the drug for the first time when it is coming from the GI tract, that is called first pass metabolism. But when it is given through IV routes, what happens? It is bypassing the first pass metabolism. Okay, so it is bypassing first pass metabolism. That's why in IV route its bioavailability is high, and when it is given through oral route its bioavailability is low. That's why fludarabine is mainly advised in IV form. Clear? This is one important point you have to remember. Next, now see, just now I told it is advised in CLL and Hodgkin's lymphoma and in non-Hodgkin's lymphoma. What is the difference between Hodgkin's lymphoma and non-Hodgkin's lymphoma? In previous class, I already told you have to remember this. You have to understand this difference. See, Hodgkin's lymphoma, Hodgkin's lymphoma, mainly B cells are characteristic feature, and in non-Hodgkin's lymphoma, it is having B cells as well as T cells. Okay, this is important difference you should remember. Hodgkin's lymphoma is mainly characterized by the B cells. And one more important characteristic feature I told. What is that? Hodgkin's lymphoma is mainly characterized by Reed-Steinberg cells. Did I tell you this? B cells, there are specific B cells which are having two nuclei in the cell, and two nuclei is having the specific nucleoli in their body. Okay, this type of particular B cells, these are B cells actually. These type of B cells are called Reed-Steinberg cells. These Reed-Steinberg cells are very similar to owl eye. See, it is like owl. Okay, and in non-Hodgkin's lymphoma, these Reed-Steinberg cells are not present. Reed-Steinberg cells are not present. Okay, and this Hodgkin's lymphoma is particularly, it is localized to the tissue. It is localized, and these are diffuse. So this is the main difference between Hodgkin's lymphoma and non-Hodgkin's lymphoma. You should not forget. So here, this fludarabine is very effective for Hodgkin's lymphoma because it is killing B cells. And here also we have B cells. In non-Hodgkin's lymphoma also we have B cells. Anyways, see, this fludarabine, first point, fludarabine is very effective in IV route. It is not available. I mean, it is not given in oral route because of its first pass metabolism. First point, when it is given through oral route. I mean, when it is administered to the body, and it is very effective for chronic lymphoid leukemia, and it can also be given in Hodgkin's and non-Hodgkin's lymphoma. That is second important point. Now, another important point, if you see the pharmacokinetics of this fludarabine, remember, just now I told in ADME of fludarabine oral is having less bioavailability, whereas IV it is having good bioavailability, number one, and it is distributed into the body in almost all the tissues. And see, this drug is metabolized in the liver. Okay, in the liver it is metabolized and it is excreted through urine. This is very simple. It is like all other drugs. There is no specific point here to understand. About fludarabine, we have to remember the adverse effects. This is important. About fludarabine, adverse effects are very important. Our main case is related to these only. Fludarabine, see, when it is, as I told, it is given in IV route. In IV route, when it is given, it will cause chills, it will cause fever, and it will cause allergic reactions. First point. So when it is given through IV route, always we have to check whether it is causing allergic reactions or not, and we have to always advise the patient that it may cause chills and fever. Okay. Next, another very important point: when fludarabine is given, it will cause opportunistic infections. Opportunistic infections. This is especially seen with fludarabine. With other drugs also that can be seen, but with fludarabine, this is very important. And next, another very important point. See, fludarabine, when fludarabine is given, fludarabine will cause transfusion versus host disease. Transfusion associated, okay, transfusion associated graft versus host disease. See, you have to remember this condition. What is it? What is that condition? See, fludarabine will cause transfusion associated graft versus host disease. Do you know what this condition is? Can anyone tell me what this condition is? See, yes, see, actually it is the opposite condition. Always remember, see, when fludarabine is given, what it causes, it will cause myelosuppression, and with that it causes opportunistic infections that I told. Okay, so in these cases, previously already I told the drugs which are causing myelosuppression. In that cases, blood transfusion is very important supportive treatment, I told, right? Blood transfusion is very important supportive treatment which is given to the patient who is having myelosuppression, because patient will have anemia, patient will have thrombocytopenia, patient will have neutropenia. With that, infection risk is there. All the things we have already discussed. So the patient who is receiving fludarabine, in that patient, if blood transfusion is done, if blood transfusion is done in blood, the donor's blood is having some lymphocytes and some macrophages. These lymphocytes and macrophages of this blood of the donor, what it does, it will go and attack to the host cell, or it will attack to the recipients. The recipient's tissues will be attacked, and it causes transfusion associated graft versus host disease. This is very fatal. This is very fatal. 90% of the cases who are on fludarabine, who is receiving this blood transfusion, they will cause this transfusion associated graft versus host disease. Always remember, transfusion associated graft versus host disease. This is very important condition. Now you have to tell me, if patient is receiving fludarabine, and in that case patient is already having myelosuppression, and blood transfusion is a drug of choice, we can't save the patient without blood transfusion. So in that cases, what will you do? Who will tell me the answer? What will you do to overcome with this transfusion associated graft versus host disease? What will you do? Who will tell? What we have to do? See, we have one. We have one treatment strategy. See, the blood which is collected from the donor should be undergone to irradiation. Irradiation. There is one strategy called irradiation. Irradiation is nothing but exposing the donor's blood to the radiotherapy. Radiotherapy is exposed to this blood. That is called irradiation exposure, irradiation strategy. In that irradiation, what happens? All the lymphocytes and other potential cells which is causing transfusion associated graft versus host disease, they will be killed. Okay, and this irradiated blood should be infused to the patient. Clear? To overcome with the transfusion associated graft versus host disease, what we have to do? We have to irradiate the donor's blood, or donor's whatever the culture or the blood or anything, that should be irradiated, and that is transfused to the patient. Clear? That is important point you have to remember about fludarabine. I think you understood about the fludarabine risk. Fludarabine के कौन से risk we have? Fludarabine is causing fever, chills due to IV infusion. Number one, it is causing opportunistic infection. Number three, it is causing TAGVHD, transfusion associated graft versus host disease. Okay, that is important. And along with this, it also causes nausea and vomiting. Another important, nausea and vomiting. So these are important adverse effects: fever, chills, opportunistic infections, transfusion associated graft disease, and nausea and vomiting. So here, see, in opportunistic infections, if patient is receiving fludarabine, here we have different uh, bacterial infections that can potentially cause to the patient who is taking fludarabine. Here, gram negative, all these bacteria can potentially attack to the body. Gram negative bacteria, gram positive bacteria, aerobes, all these fungal infections also can be seen, viral infections can be seen, protozoal infections. In this, any infection can attack to the patient who is receiving fludarabine. Okay, so this is the important point you have to remember. Now you see, I think you all understood about the important points about this fludarabine. If patient is receiving, or if patient is having opportunistic infections, antibiotics should be given. And according to the guidelines, main antibiotic that is suggested is cotrimoxazole. Cotrimoxazole is the first antimicrobial agent. They are sulfonamides. About this sulfonamides, I'll explain in one class. In chemotherapy, we'll again start with the antimicrobial agents. Okay. The sulfonamides are the initial first agent. These are very effective. Cotrimoxazole is very effective for opportunistic infections associated with fludarabine. That point you have to remember. And for graft versus host disease, for this irradiation should be done. That already we understood. And for nausea and vomiting, what you will do? For nausea and vomiting, how will you treat the patient? We will go with antiemetic drugs. We have dexamethasone. Dexamethasone is very effective antiemetic as well as anti-inflammatory agent. Along with this, we have granisetron, ondansetron. Okay, and another effective drug which is prokinetic agent, which is metoclopramide. Metoclopramide. Clopramide, very important drug. So this we have alternatives: dexamethasone, granisetron, ondansetron, metoclopramide. All these drugs can be given if patient is having nausea, vomiting, or diarrhea. In those cases, we can go with these drugs. For this irradiation we have to do. And for opportunistic infections, according to guidelines, cotrimoxazole can be given, but depend on the patient's microbial infection. Okay, based on that also we can go with the specific antibiotic which is given. Okay, and for fever and all, analgesics and antipyretics we can go. So these are important points about fludarabine. Okay, fludarabine के बारे में I think everything we have discussed. Now about there is another drug, cladribine. Just now, cladribine. This is also very similar to fludarabine, but it is having less adverse effects. And important point about this cladribine is this is specifically useful for hairy cell leukemia. Hairy cell leukemia. Actually, it is one type of chronic lymphocytic leukemia. In that hairy cell leukemia, actually these beta B cells are seen as hairy cells in this smear. Okay, that type of leukemia is called hairy cell leukemia. In that, this cladribine is very effectively used. Okay, and another drug what I told, one is pentostatin. Pentostatin. Pentostatin is another purine analog. About this drug also there is no important. This drug also is, it is similar to cladribine. It is effective for hairy cell leukemia. And yeah, adverse effects and all, it's not necessary. Okay, anyways, fludarabine is important. Fludarabine, I think I explained everything about this fludarabine. Let's go back to the case. Now let us solve this case. Now you have to try to solve this case. See, patient is on cyclophosphamide. About cyclophosphamide, already we understood about the hemorrhagic cystitis. In hemorrhagic cystitis, what we have to do? We have to go with treatment strategies already in cyclophosphamide I explained. Okay. Now the patient who is receiving fludarabine, always advise the physician that the patient can cause transfusion associated graft versus host disease. You have to try to explain about this potential adverse effect associated with fludarabine, number one. And you have to advise the physician that cyclophosphamide is one potential cytotoxic drug, fludarabine is also one potential cytotoxic drug. So in these two conditions, patient will definitely cause pancytopenia. So in this case, what you have to advise the physician to go with blood transfusion should be done, and this blood transfusion should be irradiated. First point. And next, as patient is having pancytopenia, infection risk is also very high. So advise the physician to go with appropriate antibiotic, appropriate antibiotic for this patient. And along with this, cyclophosphamide, first of all, it is having high nausea and vomiting. Along with that, fludarabine is also have nausea and vomiting as adverse effect. So in that cases, advise the physician to go with antiemetic. Antiemetic. And patient is taking rituximab. So here, when rituximab is infused, so advise the physician to check whether rituximab is causing rashes or not, because it is causing severe rashes. It can cause rashes. Rashes is the main adverse effect with this. So these are important points you have to advise to the physician when physician tries to prescribe these drugs. Okay, and along with the physician, you also have to explain the patient that these drugs can cause potential adverse effects. So when to take, how to take, and all, you have to advise to the patient. Okay, about this fludarabine, cyclophosphamide, and rituximab. These are important points. Already in previous classes we have already discussed all these things. Just for revision. Okay, I think you all understood this easy case. This is a very easy case. Now we'll go to the second case. Okay, see, a 50-year-old man who is receiving course of fludarabine, again fludarabine and cyclophosphamide, for mantle cell lymphoma. In previous class I explained about mantle cell lymphoma in non-Hodgkin's lymphoma. Actually, this mantle cell lymphoma is a type of non-Hodgkin's lymphoma. So patient is having mantle cell lymphoma. He has no other medical problems. It has normal renal and hepatic function. So what are the key counseling points which is advised to the patient when it is given with fludarabine? Again, so just now whatever points we have discussed about fludarabine can cause host associated, it can cause disease, graft versus host disease. Okay, graft versus host disease, that you have to explain. And it can cause nausea, vomiting, it can cause opportunistic infections. Okay, all these things you have to potentially, you have to explain about this graft versus host disease. This is important. Okay, so and along with this, all potential other counseling points already we have discussed. Those are points you can explain to the patient. This is also very easy case. Now I will try to tell you, this is very important. The third case, always should concentrate here. This is important, and this is very latest information. Very latest information. See, a 70-year-old woman, patient is on the treatment for chronic lymphoid leukemia, and this patient is having progressive anemia. This patient is having progressive anemia. She came to the hemato-oncologist, and she's discussing about this anemia to the hematologist, and that hematologist, he will suggest to start with ibrutinib. Okay, see, a 70-year-old woman who is on treatment for chronic lymphoid leukemia, who has progressive anemia, she discussed the treatment options with her hematologist, and will be starting treatment with ibrutinib. So the hematologist, what he did, he started, or he suggested for the treatment of ibrutinib for the patient who is on chronic lymphoid leukemia on anemia. See, in chronic lymphoid leukemia, patient may be taking fludarabine, patient may be taking cyclophosphamide, or patient may be taking rituximab. Yes, so these all drugs, especially fludarabine and cyclophosphamide, are having potentially causing myelosuppression. Okay, it is causing bone marrow suppression. So with that, it is potentiating the thrombocytopenia, pancytopenia, and it is also causing anemia. Here, all other things were not given, but patient is having anemia, that is given. So here in this case, the doctor suggested ibrutinib. Till now, there is no ibrutinib. Ibrutinib के बारे में we have not discussed. Okay, now the patient sends the prescription for ibrutinib. Okay, I mean the physician will send for the to the pharmacist, and the pharmacist, what he does, the oncology pharmacist reviews the prescription. In the prescription, he finds the ibrutinib. The pharmacist calls the patient to review her medication profile, to identify the potential drug-drug interaction, and to provide provide education regarding the administration and recommendations and potential side effects. If you are the pharmacist who is reviewing the same prescription which is containing ibrutinib, let me repeat, this patient came to you who is shifting for ibrutinib, and the same patient came to you. So what counseling points, or what advice you will give to the physician? What advice you will give to the physician? What counseling points you will give to the patient is the question. I think everybody understood. This is the case. In this case, patient is taking ibrutinib, and patient is having anemia. Due to anemia only, patient was shifted with ibrutinib. But about ibrutinib, what counseling points you will give to the patient is the question. Now, to counsel the patient, first of all, we should try to understand what is ibrutinib. Okay. See, ibrutinib is one of the Bruton tyrosine kinase inhibitor. Okay, ibrutinib is one of the Bruton tyrosine kinase inhibitor. In short, it is called as BTK inhibitor. Very latest information, and it is very famous treatment strategies. These are BTK inhibitor. In BTK inhibitors, what we have? We have ibrutinib, acalabrutinib, and we have zanubrutinib. This zanubrutinib is recently, it is approved by FDA in January 2023. Recently, this one is approved. Zanubrutinib. Okay, ibrutinib and acalabrutinib, these are approved few years ago. Okay. Anyways, now you see. First of all, we need to understand what is Bruton tyrosine kinase. Bruton tyrosine kinase. This is very important protein. It is. It is a protein. This protein is important in maturing the B cells. Okay, and due to the ability of maturing B cells, what it is leading to the B cell activation and proliferation. Simple. Actually, this is a protein. BTK is the protein. This protein, what it is doing, it is inducing the cell signaling pathway, and it is improving or inducing proliferation of B cells. Actually, these B cells are mainly characteristic feature of chronic lymphoid leukemia. Already I told. Okay, so this Bruton tyrosine kinase, this protein, what it is doing, it is improving the proliferation of B cells, and with that, it is inducing the neoplasm of chronic lymphoid leukemia. So here, if we inhibit this BTK, we can stop the proliferation of B cells. So these BTK inhibitors are recently they are approved by FDA. Okay, these are recent drugs. So in BTK inhibitors, we have ibrutinib, acalabrutinib, and zanubrutinib. These are important drugs. Along with this, we have few other drugs also. This is ibrutinib, acalabrutinib, zanubrutinib. This is recently approved, 2023, and these are not yet approved. This the tirabrutinib, and they are under clinical trials. These two are under clinical trials. These three are already approved. Okay. Anyways, now you see. Now I let me tell you the important points about this BTK inhibitors. These BTK inhibitors are the substrates of cytochrome P450 enzymes. In previous class, I told if patient is taking the drugs which are metabolized by cytochrome P450 enzymes, in that cases we have enzyme inducers and enzyme inhibitors. In enzyme inducers, what we have? CRAB GPS. CRAB GPS. These drugs should not be given if BTK inhibitor is given. Why? Because CRAB GPS, what they do? They will induce the enzymes and immediately these BTK inhibitors will be rapidly metabolized. And these BTK inhibitors also should not be given with enzyme inhibitors. In enzyme inhibitors, what we have? In enzyme inhibitors, we have sickfaces.com. Sickfaces.com. I already told all these drugs. CRAB GPS means here C indicates R, rifampicin, A, alcohol, phenytoin, graceolpulvine, phenobarbital, sulfonyl ureas. And in sickfaces.com, we have sodium valproate, isoniazid, here ciprofloxacin, ketoconazole, fluconazole, alcohol, and here chloramphenicol, erythromycin, and sulfonamides. Again, C is here. I think this is cimetidine, omeprazole, metronidazole. Okay, anyways, these are the different drugs which are enzyme inducers and enzyme inhibitors. Along with these drugs, BTK inhibitors should not be given. First point. Second, always avoid proton pump inhibitors and H2 blockers when they are given with BTK inhibitors. Number two. Number three, diarrhea is very, very common with BTK inhibitors. Very, very important. Diarrhea is very common with BTK inhibitors. And BTK inhibitors can inhibit platelet aggregation and that can induce bleeding. So, always never suggest warfarin or aspirin with BTK inhibitors. Next, other adverse effects it can cause arthralgia. Arthralgia means joint pain, body pain. Atrial fibrillation, it can cause atrial fibrillation. It can cause hair and nail changes. It can cause headaches, hypertension. Hypertension is important. And it can also cause infection and rash. Okay, these are potential adverse effects which is associated with BTK inhibitors. Now, patient is taking ibrutinib. Okay, ibrutinib is one of the BTK inhibitor. So this patient came to you. So what will you suggest? Because now just now you have understood all side effects and all. So what points you will suggest? See, if patient is taking any of these drugs, advise not to take either enzyme inducers or enzyme inhibitors with these drugs. If patient is taking enzyme inducer, increase the dose of BTK inhibitor. If patient is taking enzyme inhibitor, reduce the dose of BTK inhibitor. Over. Avoid PPIs and H2 blockers. This is important. You have to advise the patient not to take PPIs or H2 blockers when BTK inhibitors are taken. And always counsel the patient that BTK inhibitors can cause diarrhea. So advise BTK inhibitors especially at night, only after food. Okay, at night time you have to advise after food. That will decrease diarrheal adverse effects. Okay, now and always advise the patient not to take warfarin or aspirin, or they should be away from the accidents or any other sharp items. They should not play with sharp items, because it can inhibit platelet aggregation and it can potentiate bleeding. That is another important counseling point you have to advise to the patient. And all other adverse effects, these are minor adverse effects, but these are potential adverse effects. If patient is having arthralgia, advise the patient to take analgesic, especially acetaminophen can be given. Aspirin should not be given. One, if patient has atrial fibrillation, if patient has atrial fibrillation, you can go with beta blockers or advise the patient with warfarin with very, very low dose warfarin. And if patient has hair and nail changes, advise the patient to take with biotin. Okay, always give biotin. If patient is having hair and nail changes, hair discoloration, anything, if hair fall is having, in that cases, biotin tablet should be advised. And if patient had headaches, again, you can go with opioid analgesics or we can go with acetaminophen, paracetamol. If patient has hypertension, always advise AC inhibitor here. AC inhibitor here in the patient. And if infection is there, particular antibiotic should be given. If rashes are there, we'll go with antihistamines, or we will try to infuse the drug, or we will mainly here antihistamines are suggested. So these are important points. The side effects of BTK inhibitors. Okay. So yeah. So I think the third case also you understood. So I think you all understood about this Bruton tyrosine kinase inhibitors. Clear? Clear, everybody? In this, do you have any doubt? We discussed mainly about fludarabine today, fludarabine and purine analogs we have discussed, and we have discussed three cases. And in tomorrow's class, we'll try to continue with the pyrimidine pharmacology, pyrimidine pyrimidine analogs and methotrexate. Okay, methotrexate and pyrimidine analogs are another anti-metabolite drugs. We will discuss those in the tomorrow's class.